Great, great. So first of all, on behalf of TransCan and also the webinar series that both Ingrid and myself coordinate, we welcome all of you to the very first TransCan webinars presentation. For those of you all who are not familiar with TransPan, and I hope it's actually quite a lot of people because that indicates that there is potential for future collaborations and new incorporations. TransPan is part of the cost action program from the European Union. Specifically, TransPan is the identification of biological markers for prevention and translational medicine in pancreatic cancer. We invite all of you to either scan the QR code that you see on your screen, or you can access our TransPan website via transpan.eu. Now, TransPan is a coordinated effort. There are many countries that are involved in this. It's coordinated both by Federico Cancian and Daniela Campa, which are here today. So if you have any questions about TransPan, you can definitely ask them. The main aim of TransPan is to develop better tools for risk stratification of pancreatic cancer. We're all here because I think we all have an interest or a common interest in pancreatic cancer. And so we hope to develop better tools for risk stratification through integration of genetic and non-genetic factors in the general population and or in specific subgroups at higher risk for pancreatic cancer, such as familial pancreatic cancer. And there are four working groups. Working group 1, which specifically is involved in disease risk profiling. Working group 2 for the development of non-invasive biomarkers or the detection of new biomarkers. Work group 3 is tumor profiling, and work group 4 is functional genomics and therapy. So this is important because all of our TransPan webinar series over the course of the next few years are going to be focused and based and with a specific focus on these working groups. So initially, both Ingrid and I decided that it would behoove us all to have a better understanding of pancreatic cancer. So we will initiate the webinar series with 4 talks. 4 seminars. These are monthly seminars. The first 4 will be more on the clinical aspects of pancreatic cancer, and then we will get more into the nitty-gritty details, the more biological translational studies, focusing on each of the work groups that are involved in TransPan from work group 1 until work group 4. The main speakers will be TransPan members, but of course we invite other people outside of TransPan that can also participate in the webinar series. As you can see, the webinar series are being recorded. They will be internally used within the TransPan consortium, but we'll also provide certificates for those of you who need it, especially PhD students who might be able to use these webinar series for their specific PhD programs. And so we invite you all to take a look at TransPan, see our initiatives, what our goals are, and we also invite you to join us. So this is not a closed consortium. We can recruit and invite new members at any time. So please take a look at the requirements for entry, apply. So quick apply button. You can follow the instructions on the screen, which will lead you to potentially being a new TransPan member, which we invite you all to take in consideration. So I don't want to take up more time from Ingrid. So Ingrid, if you want to share your screen, we have 64 participants connected. I think that's fantastic for our first webinar series. So while Ingrid's sharing her screen, it's my pleasure to introduce her. Ingrid, or Dr. Garajova, is an MD, PhD. She's going to give our talk today entitled Pancreatic Cancer and Clinical Unmet Needs, which we think is a great idea of why we're all here. What are the unmet clinical needs that we have right now in the pancreatic cancer field? Ingrid is a clinical oncologist with a particular interest, obviously, in pancreatic cancer. She's working in the medical oncology unit at the University Hospital of Parma in Italy. She has a fantastic CV, a number of publications. She's involved in many outreach programs and members of different associations. For example, she's a member of the Oncology Task Force of the Italian Association for the Study of Pancreas, and also co-chair of the EORTC Pancreatic Cancer Task Force, and a member of the Pharmacology and Molecular Mechanism Board as well, part of EORTC. So it is a pleasure for us, Ingrid, to have you kick off this seminar series. I think we'll all learn a lot from your presentation. If you don't mind putting it on a full presentation mode, and then we can start with the presentation. Thank you, Ingrid.
Okay. Thank you very much, Bruno, and welcome everybody to this first transplant webinar. And I'm very happy to welcome you to this first talk. We will talk about pancreatic cancer and the management of pancreatic cancer from the clinical point of view. As Bruno said, I'm a clinical oncologist, and I will try to explain you how we manage pancreatic cancer patients. We will start with a short introduction. Unfortunately, pancreatic cancer has the worst 5-year relative survival rate among all solid tumors, just 13%. And in other words, it means that 87% of our patients will die. And pancreatic cancer is the 4th leading cause of cancer mortality in males and the 3rd in women. And unfortunately, also the future is not bright, because if we are looking at the projection of pancreatic cancer incidence and mortality in Europe, we see that it's increasing. And it's increasing by about 1% annually, both by men and women. And it is predicted that pancreatic cancer will become the 2nd leading cause of cancer-related death. We will also talk shortly about risk factors that are associated with the pancreatic cancer, such as cigarette smoking or heavy alcohol consumption, but also the obesity and metabolic syndrome, chronic pancreatitis, and diabetes mellitus are among the risk factors that increase the incidence of pancreatic cancer. Moreover, we have a family history of pancreatic cancer and 13 germline mutations, which also increase the possibility to have a pancreatic cancer during the life. From the clinical point of view, the majority of our patients complain pain, which might be abdominal pain or the back pain, which is very frequent in pancreatic cancer patients. And then we can see the symptoms which are due to the infiltration of the pancreas to adjacent organs. So, for example, to the duodenum, so the patients can have a nausea or vomiting, or they can compress the biliary tract system, so they have a jaundice. And also, new onset of diabetes is connected with pancreatic cancer diagnosis. And there are so many other unspecific symptoms, such as loss of appetite, loss of weight, and the fatigue, which are really connected with the pancreatic cancer diagnosis. So what is important for pancreatic cancer staging is the CT scan. So we perform to all of our patients CT scan, both of the thorax and abdomen. And as you can see in this CT scan, there is a big mass of the head of the pancreas. So this is the pancreas, and this is the head of the pancreas. And we usually see the hypodense mass, which is hypodense mass typically on the CT scan. Moreover, before any start of chemotherapy, we need pathological proof of this disease. And in the patients that do not have metastasis in the liver or at the other side, we use echo endoscopy to provide the biological proof. For the patients that have a distant metastasis, for example, in the liver, we prefer to do the biopsy of the liver because we can obtain more tissue. Moreover, as a staging procedure in the patients that do not have distant metastasis, so we are talking about resectable and borderline resectable pancreatic cancer, we usually use also the liver magnetic resonance because it is more specific to reveal acute liver metastases. And of course, before any treatment, we need to do the blood test, which include also enzymes that are involved in the metabolization of our drugs, and also tumor markers, in particular CA19-9, which is the only marker that we are using in clinical practice. Moreover, before the treatment, especially if we are thinking about fluoropyrimidines to use in the treatment of the pancreatic cancer, we refer patients to oncocardiologists because of potential of cardiotoxicity of our drugs. So in the clinical practice, we don't use TNM classification for this tumor, but we are classifying the pancreatic cancer into resectable, borderline resectable, locally advanced, and metastatic pancreatic cancer. This is very important for the therapy of the pancreatic cancer. So very shortly, what it means, resectable pancreatic cancer. As you can see in the cartoon, we have a tumor and we have a vein and arteria, superior mesenteric arteria and superior mesenteric vein. And as you can see, there is no contact between the tumor and arteria and vein. So in this case, when there is no contact, no vascular contact between the tumor and the vein or the arteria, or there is just a small contact with the vein, we are talking in general about resectable pancreatic cancer. And you can see the picture, the CT scan. So we can see the hypodense mass, so the black one, which is the tumor, and no contact with arteria or vein. Borderline resectable pancreatic cancer is that one where there is a contact with arteria. So you can see it in the cartoon this way. There is a contact with the arteria, but this contact has to be less than 180 degrees. You can see it in the picture above. And this is also important criteria for borderline resectable pancreatic cancer. So look at the CT scan close. So as you can see the tumor in the red, and you can see also a contact with superior mesenteric arteria, which is less than 180 degrees. So this is, according to our classification, clinical classification, borderline resectable pancreatic cancer. Locally advanced pancreatic cancer is that one that has a very big contact with arteria, so more than 180 degrees. And you can see in this scan where all the vein and also the arteria is infiltrated, unfortunately, by the tumor. And the last category is the metastatic pancreatic cancer. When we see the distant metastases in any side of the body, so in this case it is liver, but it can be also lung or peritoneum or whatever. Unfortunately, the majority of the patients are diagnosed with locally advanced or metastatic pancreatic cancer. So the problem in the pancreatic cancer is also the late diagnosis. Only 10 to 20% of pancreatic cancer are considered resectable or borderline resectable. So even if we are talking about early pancreatic cancer, it is quite difficult to treat also this disease. And it is because even after potentially radical surgery, the recurrence rate is very high. It is about 85%. And unfortunately, in the majority of the cases, this recurrence is systemic in 76% of the patients. And this underlines the systemic nature of the pancreatic cancer, even if the clinical presentation is that of the local disease. And therefore, even if we have anatomically resectable pancreatic cancer, we are looking with suspicious eyes. And therefore, in the last years, there is a trend to use neoadjuvant approach even for resectable and borderline resectable pancreatic cancer. Neoadjuvant means that we are using the chemotherapy or radiotherapy before surgery. And the hypothesis is to spare the surgery to the patients that have already metastases that we cannot see, and therefore there is no necessary of surgery. For the borderline resectable pancreatic cancer, there is absolute indication to use the neoadjuvant chemotherapy where it is possible. This is, for example, AISP trial, which shows us how outcome of our patients with borderline resectable pancreatic cancer increase when we start with any kind of approach of neoadjuvant treatment. And as you can see in this trial, different approaches for neoadjuvant treatment were used, but seems that using the chemotherapy and especially the 3 drugs combination chemotherapy is the most convenient for these patients. The role of neoadjuvant chemotherapy in clearly anatomically resectable pancreatic cancer is not that clear. Even if we have different randomized trials, and we have also 2 meta-analyses which were published this year, there is not that much clear evidence for resectable pancreatic cancer approach. Anyway, we are looking for the results for another studies, phase 3. We know that adjuvant therapy, so the therapy which is done after surgery, has to be done for the patients that are fit for it. We have different possibilities of adjuvant therapy in pancreatic cancer, and even if we are using just 1 drug, for example, gemcitabine, we can double the survival of the patients in 5 years. So as you can see, patients that are treated just with surgery, 10% of surveillance. And when we are doing adjuvant therapy with the gemcitabine, we have a survival. We have a doubled 5-year overall survival. And we can increase ulteriorly this overall survival when we are using 2 drugs, gemcitabine and capecitabine. And if the patients are fit enough to use to be treated with a 3 chemotherapy regimen, which is called modified FOLFIRINOX, it can provide the best 5-year overall survival of 43%. So if you want to conclude this part of resectable and borderline resectable pancreatic cancer, we know that for resectable pancreatic cancer, we can also think about surgery upfront, but never for borderline resectable pancreatic cancer, where the indication is initiation of systemic treatment. Anyway, the question is not that easy, because even if we see the pancreatic cancer, which is anatomically resectable, there are a lot of high-risk factors. For example, the tumor marker CA19, if it's very high, so for example, more than 500, the outcome of these patients is bad. And therefore, even in clinical practice, even in patients with resectable pancreatic cancer, but with high tumor marker CA19, we consider it as borderline biological borderline pancreatic cancer. So CA19 matters for surgery evaluation clinical practice. So we have, fortunately, also the new directions in neoadjuvant and adjuvant treatment in pancreatic cancer. And in particular, there are aims to divide pancreatic cancer according to RNA expression profile. And as it was seen in metastatic setting, that basal-like tumor are resistant to FOLFIRINOX. So to treat them in neoadjuvant setting with gemcitabine and nab-paclitaxel. And in contrast, the patients with a classical subtype of pancreatic cancer should theoretically receive FOLFIRINOX. And I would like to cite also a trial that was published in Nature in 2023, where the patients after resection of pancreatic cancer were treated with standard of care, which is modified FOLFIRINOX, but they also received vaccine that included of about up to 20 neoantigens, which were specified for dead patients. And it is a small study of only 16 patients, but half of these patients have an immune response to this vaccine, and they are called responders. And these patients, as you can see in this graphic, have a very good outcome. Now we will pass to metastatic and locally advanced pancreatic cancer, and we will see which kind of drugs we can use really in clinical practice today. So the first thing that I would like to say is that unfortunately, if we are treating metastatic pancreatic cancer in clinical practice, the intent is that one of palliation. So in the first line of palliative chemotherapy, we can use different drugs. We can use fluoropyrimidine in endovenous form or capecitabine in peroral form, irinotecan or oxaliplatin. And we can create the regimen, which is called FOLFIRINOX. Or we can use gemcitabine and nab-paclitaxel and to create this regimen. And these are the regimens that we are using in the first line setting in pancreatic cancer. In the second line, we can use the same drugs as in the first line, but we have also the possibility to use liposomal irinotecan. So the first line, standard first line therapy that we can use in pancreatic cancer are substantially three. So we know that FOLFIRINOX gives better results in comparison to gemcitabine. We can use gemcitabine and nab-paclitaxel, which is better than gemcitabine. And a couple of years ago, Napoli 3 trial was published where NALIRIFOX showed better results in comparison to gemcitabine and nab-paclitaxel. NALIRIFOX is the combination of oxaliplatin, liposomal irinotecan, and fluoropyrimidines. So we know that NALIRIFOX is better than gemcitabine and nab-paclitaxel, but there are no head-to-head comparison between gemcitabine and nab-paclitaxel and FOLFIRINOX, and between FOLFIRINOX and NALIRIFOX. So as you can see, whatever treatment we are using in the clinical practice for these patients, the outcome is less than 1 year. And unfortunately, it is really very difficult to treat these patients because the majority, around 80% of our patients will have a pain and so many other clinical difficulties. As the standard second-line therapy, we can use the combination with oxaliplatin or the combination with irinotecan. And in the clinical practice, where it is possible, we prefer irinotecan-based combinations because, as you can see, there are two randomized phase 3 clinical trials for oxaliplatin-based combination in the second-line treatment with contrasting results. So when we are choosing the therapy for our patients, we have to consider several factors. The first are patient's characteristics. So in particular, its comorbidities, performance status, age, and also the prior adjuvant treatment. We also consider tumor characteristics. So we consider if it is metastatic or locally advanced pancreatic cancer. For locally advanced pancreatic cancer, we are using the same therapy that we are using for metastatic pancreatic cancer, but we prefer to use FOLFIRINOX where it is possible because there are some evidences that in the patients that will not undergo surgery, the outcome with FOLFIRINOX is better than gemcitabine and nab-paclitaxel. The possibility of surgery for locally advanced pancreatic cancer is not that high. Just around 20 to 30% of the patients will arrive to surgery after the treatment for locally advanced pancreatic cancer. So another characteristics that we have to consider are molecular characteristics of the patients. If we know that the patients have, for example, BRCA1 or BRCA2 mutation, we tend to use platinum-based chemotherapy. We unfortunately don't have any randomized clinical data, but we have a lot of retrospective data that show us that using platinum-based regimen for this kind of patients might confer outcome benefit. We have also a phase 3 randomized clinical trial with olaparib, which is PARP inhibitor, as maintenance therapy after platinum-based treatment. And it is positive for progression-free survival, which was the primary endpoint for this study. And the last thing that we have to consider is also the patient's preference regarding the quality of life or the toxicity profile. So from practical point of view, we have two possibilities of the chemotherapy in the first line. And as I told you before, we do not have a head-to-head comparison, but we have an indirect comparison between these two regimens, and seems that according to the efficacy of the treatment, progression-free survival or overall survival, the efficacy is similar. And regarding the second-line treatment, there are no head-to-head comparison, but there are several meta-analyses, for example, this one. And this shows us that just irinotecan-based treatment in the second-line treatment confer progression-free survival, but also overall survival advantage. The platinum-based not. One of the last slides that I would like to show you is these two real-life studies. One is in a European real-life study, and one is United States real study. And this is just to show you that just 50% of patients in Europe can receive, because of good clinical conditions, also the second-line treatment. In United States, it's even less, about 40%. And the best combination, as a sequence, seems both in Europe and United States to start the treatment with FOLFIRINOX and then continue with gemcitabine combinations. But as you can see, the overall survival both in Europe and United States remain really very, very poor. We have also new directions of the treatment of metastatic pancreatic cancer, and we will dedicate to this webinar, the next webinar. But I just would like to show you the new KRAS inhibitors that are coming to the clinical practice, and some of them we have a possibility to use. 90% of the pancreatic cancer have a KRAS mutations, and the most frequent is K12D or G12V. In clinical practice, we have a possibility to contrast 12C, which is very rare in pancreatic cancer. It is less than 2 or 3%. But in this subpopulation, we have two studies with sotorasib and adagrasib with quite interesting results. But there is ongoing phase 3 trial with pan-RAS inhibitors and also inhibitors of KRAS 12D. The last thing that I would like to tell you that it is quite important to proceed with the next generation sequencing, especially in the patients that do not have KRAS mutations, which are quite rare, less than 10%. But especially in this subpopulation, we can find some genetic alterations that are potentially targetable with some drugs. So I would like to conclude this first webinar that unfortunately for what I see as a clinicians, there is a lack of high quality data for randomized controlled trials for pancreatic cancer. We are missing in clinical practice stratification of optimal candidates for systemic treatment and the type of treatment. And of course, the precision medicine in non and metastatic pancreatic cancer remains an urgent and unmet need. Thank you very much for your attention.